Good afternoon, everyone. To those joining us for the first time today, welcome. We're so glad you're here at the TxRx Echo. And to those that are returning, welcome back. Thank you all for joining the TxRx Echo, brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by Be Well Texas in collaboration with the UT Health San Antonio Echo program. My name is Angela Riley. My pronouns are she, her, and I will be the facilitator for today's session. A few housekeeping items before we begin. To help us with attendance, please enter your full name, affiliation, and email into the chat. Please remember to stay muted unless you are speaking. We do encourage using the chat and/or raise your hand feature to pose questions or share your perspectives throughout the session today. If you're having connection issues, please privately chat Karen, our wonderful Echo IT, for further assistance. And as a note, these sessions are being recorded and they will be shared on our website. Therefore, to ensure privacy, no personal health information is allowed at any point throughout the session. And this includes names, addresses, birth dates, or any other identifiable information. At the end of the session, the ECHO team will send out a post-session survey link. We kindly ask that you complete it as it provides us feedback on how to refine these sessions to better address your priorities. Finally, ECHO is an all-teach, all-learn environment, and we do encourage everyone to participate in the conversation and raise questions. Let us always make every effort to continue having a space that is respectful and safe to learn for all. With that, we will move on to team introductions. I will begin with Dr. Weems, who is also our lead specialist for today.
Everybody, John Weems here. I'm an internal medicine doc and addiction specialist here at Community Care, Big FUHC in Austin, also a member of our SHOUT team, and super excited to learn from one of our SHOUT stalwarts and longtime mentor, Dr. DeMoss today, and then our amazing to-be chief resident, Dr. Ariel Hurwitz, who will bring a great case.
Thanks, Dr. Weems. Dr. Kowalczyk.
Hi, I'm Alicia, Dr. Kowalczyk. I'm in family and community medicine here at Baylor College of Medicine. I'm also medical director at Santa Maria Hospital and boarded in addiction and family medicine. Thank you.
Thanks, Dr. Kowalczyk. Dr. Walker.
Hey everybody, Crystal Walker, doctorally trained PA, and I am the director of the substance use department for MHMR of Tarrant County, both the medical and the clinical side. Welcome, happy to be here.
Thanks, Dr. Walker. And our presenters for today, we have Dr. Ariel Hurwitz will be presenting our case. Dr. Hurwitz.
Hi, good morning, everyone. Very honored to be here. I'm Ariel Hurwitz. I'm a PGY2 internal medicine resident here at Delsey Medical Center.
Thanks for being here, Dr. Hurwitz. And finally, Dr. DeMoss.
Hi, Dustin DeMoss, Program Director for the Psychiatry Residency at JPS and Vice Chair of Education, boarded in internal medicine, psychiatry, addiction medicine, and I'm just honored to be with such a great team, John and Crystal and all you guys. It's been a fun ride, and I'm looking to continue the journey.
Thank you, Dr. DeMoss. Thank you all for your introductions. If you haven't already, please introduce yourself in the chat. I do see lots of introductions coming in, so that's exciting. And with that, we'll get started with our didactic presentation. Dr. DeMoss, you may take it away.
All right, thanks, Angela. So I don't do PowerPoints, I try to do as very little as possible. I want this to be interactive. But they made me put something together, so I threw some slides together for you guys. But as John and Crystal and the rest of you who know me, I'm very much interactive person. So if you have questions, comments, whatever, just throw them out. I'm gonna show some slides, and then I'm gonna try to come off, and be on camera more. So just I'm sorry, and you're welcome. Let me go ahead and share a little bit. All right, so it's kind of cheesy, but I'm a cheesy kind of guy. So, there's a saying, be the change that you want to see, right? So that's where the title came from, be it so others can see it. have no disclosures. The objectives, organizational change. I'm going to show you 4 steps. I can never remember anything longer than 3. So that's my disclaimer. And then we're gonna give you some strategies how to gain buy-in. And then lastly, we're gonna wrap up with how to avoid pitfalls. It's more elegantly stated in the objectives, but that's what we're gonna get through. So step number 1 is identifying the need. I just went on to Google and saw what San Antonio needed as listed by their community health needs assessment. Okay, so this is where I'm gonna come off. I'm sorry if I'm gonna make you dizzy, but has anybody seen or know about their county's community health needs assessment? Raise your hand. John, I know, and of course, Crystal. Anybody else? Okay, Lindsay, I saw a hand, thank you. So a few. Okay, Alana, actually. If you don't, this is probably where you want to start. If you're not already working in a substance use treatment, be it inpatient, outpatient, but you know something's got to change at your institution, find the change in here, because undoubtedly somebody in your county, in your community, has put together a list of things that they need help with. And that's called the Community Health Needs Assessment. Most counties do it every 3 years. And that's definitely the case for San Antonio, Bexar County. And y'all should be conducting another one this year. So that's step number 1. What does the county need? And obviously, I think the vast majority of counties in the state of Texas probably share this same need. So identify the need. Step number 2. Make sure that need is in line with what you're doing, your institution's doing, your university is doing. This is UT's missions, goals, and values. A lot of the institutions will say, oh, we can't support that project because it doesn't align with our mission, goals, and values. Well, if you're in the substance use world, like most of us are, most counties have identified a need that relates to substance use or maybe even behavioral health or the combination thereof. And I guarantee you, most of your institutions are driven or have some wording in their mission, values, and core beliefs that align with that need. So once you have found the community need and how it ties to your institution's mission, that's step number 2 in creating the business case or implementing change. All right, making sure it's there and making sure it's in alignment with what your institution's trying to do. Step number 3 is it's cost, but I know the slide says, has dollar signs, so that makes you think money. There's other costs that have nothing to do with money, and I'll talk about that in a second. So what you want to do in the 3rd phase of change implementation is identify what it will cost to make the change, but also pay a lot of attention to what it's going to cost your institution with their grand mission, values, and beliefs and cores of what it will cost if they don't do it. All right. And that goes beyond just, you've heard ROI or return on investment. And that's a lot of times, are we going to make money if you're a for-profit organization? And for not-for-profit, you're supposed to be not losing money, which is reasonable. You want it to be sustainable. But all of that conversation has to relate to the cost of implementing this and also the cost of not implementing this. So, and then I put this slide up there as a throwback to Rich Botner days with UT Dell and Shout. He gave this slide to me way back when, and I thought this one and the next one actually, I thought it was very telling and very striking that substance use treatment costs so much, and just the one figure I want to highlight here is this one. 1% of all hospital expenditures. And once you start talking to, people who have that 30,000-foot view, usually in the C-suite, they don't, they may pay a little attention to what OUD costs versus what osteomyelitis costs or what something else may cost. But when you talk about, percentage of hospital expenditures, their ears start perking up then. And this is, probably what, 6, 8 years ago now. And so 1% has probably grown since then. But if you say 1% of all hospital expenditures, you're going to get some ears. So that's the money cost. But whenever, I'm trying to get people who are wearing suits to change their mind, I will always want to bring it back to patients. So what does it cost to the person? What is the individual cost? And that's where this comes in. They costs them, they feel bad. They may have incurred personal and guilt costs with sexually transmitted infections. And then they may incur other costs, a bad heart, a bad liver, and the other imaging and, kind of diagnostic workup costs for those, for those personal costs of untreated substance use disorders. All right. So that was 3 as, learning objective number 1. Those are your 3 main objectives that I want you to walk away from today, or 3 main steps of change implementation that I want you to walk away from today. Identify the need, make sure it aligns with your institution's mission, values, and goals. And then what is the cost of, and what is the cost of not implementing the change that you're wanting to see. The 4th step, super easy, because most of the time, it's these folks who are doing the actual work, and this is identify your champions. I put the picture up here, John, Alana, Maddie, our own Shout champion here. This was 2024's in-person Texas Shout Summit. And so these are all champions here. And so just a quick shout out to this group. But that is the 4th step, identifying a champion. What I have found over the last, decade plus of being here and doing this kind of work is the champions are the ones driving this. The champions are the ones leading this anyways, and they identify themselves. And most of us, you've either, had an experience, or you're in an institution where there's a vacuum and they need a champion. Champions will emerge, and they're the ones who are likely going to be leading this work. So, all right. To round this out, how do you get buy-in? 3 main ways that we've gotten buy-in here at JPS in Fort Worth. One is go to where the patients are. And, a lot of it was in the ER here. A lot of it was in our inpatient medical hospital here, and inpatient psychiatric hospital as well. And we say, hey, have you cared for somebody with opiate use disorder? Oh, yeah, tons. Have you cared for somebody with methamphetamine use disorder? Oh, yeah, tons. And you ask them, well, where do you send them for follow-up? Or how do you feel like you have the tools that you need to care for these people efficiently and effectively? Vast majority of the time, it's no, especially if you're in some of the institutions around here. And you ask them, is that, how do you feel about that? Are you frustrated? Do you want to try to be part of the change that we can, make that better? And hands down, you're going to get willing participants. The second point is, I like this one because this one gets to the hidden agenda here, which is, also changing people's thoughts, attitudes, and beliefs about substance use disorders. And I'll go to the ER, I'll go to the inpatient hospital, and I'll say, hey, you ever care for people with OUD or methamphetamine use disorder? They're like, oh, yeah. And a lot of times they'll use stigmatizing language, those, druggies or whatever, vernacular they're going to use. And you play to their bias, use their bias against them. Like, hey, would you like to help lead change so we can help care for those folks more effectively and more efficiently. And they're like, yeah. And then the more they lean into the work, people with bias, the more they see that this is actually a chronic, relapsing, remitting medical condition. And then their minds change themselves through the work that they're already wanting to do anyways. So, and then lastly, we found this here, and if you're a teaching institution, super easy to do. Leverage the populist interest, meaning here we have a lot of family medicine residents, and obviously, they're very dedicated to being able to take care of anything and everything in their outpatient clinic or wherever it is they are. And they were, very hungry to get buprenorphine on the formulary here and learn how to prescribe. And so that gave us a lot of leverage to go to their attendings who may be a little bit more mature and further away from training, I should say. And maybe they were still like, oh, well, that's specialty care, right? They don't you need the special training and stuff I can't do that. Some of the residents and learners were like, no, we can do that. And so anyways, that's another way to help garner buy-in is leverage the populist interest, leverage the trainees who are gung-ho, ready to come out, do the work. That's motivation. That is momentum that will just help you in your change agents to make those things that you want to see. And lastly, this is avoiding pitfalls. Don't do what we did, which was you got just a group of champions. You got a bunch of docs and nurse practitioners and PAs are like, let's do this. We're going to take on the man, or we're going to climb the hill. We're going to die on this hill, which is great. You want that enthusiasm, you want that passion, but it's got to be more than just providers. It's got to be more than docs, PAs, nurse practitioners. You got to include administrative staff. You got to include nurses. You got to include social workers, because you're focused on providing care and providing treatment, right? You're not focused, and you don't know that if you add a nurse practitioner, a PA, or physician in a clinic, well, you're also going to need some nursing support staff, maybe some, CMA time, some PAR time, some peer support time. Oh yeah, we might need some of that. So have somebody watching those blind spots for you, and get them in early and get them in often on some of those decision-making conversations. Because once you have those elements in place, then the executive team, the C-suite, is going to say, okay, fine, we'll give you this clinic, or we'll give you this one thing that you're asking for. What's next? How are you going to make it sustainable? Well, okay, how do you want to grow? How do you want to scale? So have a strategic plan. Have an idea of what your perfect system looks like, and then start walking back from there until you get to step one. And then lastly, regulatory. We started it off on OUD in the BUP world, and thankfully the regulatory restrictions were lifted. And so, all right, we're going to do this right, and everybody can do it. Depending on what you call yourself, you can be, a co-occurring clinic, which is what we have. If you want to call yourself a chemical dependency treatment facility, right, Crystal, then you have other regulatory hurdles to jump over and through and around, and I wouldn't recommend under. And so having somebody who has intimate knowledge of each one of those steps is worth their weight in gold. So having a regulatory champion by your side, leading you every step of the way to help you avoid things that you really want to avoid is just highly recommended. So with that, shout out to all of our team here for all the help that they've done over the last several years. And I'm gonna stop the PowerPoint. the death by PowerPoint now. So happy to take any questions. Always good to see my good friends and colleagues.
Thank you so much, Dr. DeMoss. And yes, the floor is open for questions or comments.
I'll say one more thing. This is, I based most of this on what I see and what I know, which is primarily academic places. The areas that I have blind spots on and or probably need some additional, help is carceral settings. I know the jails and prisons, a lot of change needs to happen there. But then also maybe some, private practice settings, concierge medicine. There's a lot of places where similar pieces can be taken from here and implemented in some of those other places. But I know the carceral setting is one that is definitely in great need of. Sorry. In the chat, listen.
Oh, go ahead.
I was just gonna say, Sandra, I'm happy. Yeah, y'all can have, whatever slides you want. I sent it to Angela and Jasmine. They're happy to distribute.
Yes, and as mentioned at the beginning, the session is being recorded and will be shared on our website, so the whole thing could be serve as a reference as well. Carolyn, I do see that you're unmuted. Did you have a comment or a question? Okay, probably not. Dr. Weems, you had unmuted as well.
Yeah, thanks, Dr. DeMoss, so much. I'm hoping to tap into your clinician educator toolbox here. I love how you mentioned, kind of using MI to help, address less of people's sustained talk and encourage their change talk to be a part of that solution. And then you also called out, the gung-ho residents and any specific advice. We have a great case from a resident doc. Any advice for learners as they're encountering the bad old ways? You're kind of in the midst of change and how to, on the one hand, advocate for what we know works and the evidence-based approach, and at the other hand, navigate the kind of the curriculum and hidden curriculum of being a trainee early on in professional identity formation.
Yeah, absolutely. Thanks for the question, John. So what I find some of the mature folks and kind of stuck in their ways folks very, very susceptible to is standard of care or standard practice. Some of these buzzwords, which, as we know, standards of care change. It is now standard, for example, somebody who comes into the hospital with opiate use disorder, inactive withdrawal. We no longer detox or manage their withdrawal symptoms and get them out on nothing. That is no longer standard of care. Standard of care is to manage their withdrawals appropriately, effectively, and then discharge them with some medications to assist with their ongoing recovery. And so that's now standard. And so if you have an attending or a supervisor saying, oh, we're not doing that specialty care, you can reliably say, well, I thought the standard of care was, or isn't it current, acceptable current practice to use some of those buzzwords that perks their ears up as well.
Thank you, Dr. DeMoss. Any other questions or comments? I do see a question from Megan in the chat. What is the go-to resource for defining standard of care, especially with OUD?
Oh, fantastic. There's a couple. I think the easiest one that I would point people to is the American Society of Addiction Medicine, ASAM. They seem to be referenced a lot when you look at federal regulations. So you hear about the DEA coming out with a final rule on something. Last year, they came out with a final rule on methadone. There are some telehealth final rules that have come out. And a lot of times they'll cite some resources, and a lot of times it is, ASAM criteria, ASAM recommendations, ASAM guidelines, etc. So the American Society for Addiction Medicine is a great place to go to find, current standards of care.
Excellent. Thank you. I do see Dr. Lindsay shared in her words, a good resource for using motivational interviewing and leadership in organizations. So
Yep.
everyone should click on that and have that saved on their desktop or, their window.
Good resource, Lindsay.
I got one more question as our systems are transforming to be more focused on people with lived experience and kind of centering patient experience, if we look at the quadruple aim, and especially with substance use disorder, and then abatement dollars are flowing to often fund peers to get into our spaces. Any advice for both learners and those of us who are still learning further along for how we talk to very established systems about just how important peers are and how they fit into clinical arenas?
Thank you for that question, John, because it is folks with lived experience who can navigate patients through what they already know, their the paths that they have taken, and it's patient stories that I think a lot of times have a significant impact. And let me make this very tangible. Going back to the community health needs assessments, every county has their county commissioners court or board of directors that are open to the public. And man, if we had time, I would pull up a clip of our board of managers meeting that was open in February, and the patient stories that come up from that one is remarkable. And I wanted to go the very next day to the C-suite and be like, hey, this YouTube clip that you saw last night, that's why you need me and you want to give me money so I can go build things that they demand and you want. So check those out. Those are very, poignant, tangible, and you can just feel the emotions coming from patients and patient families. And that is what will drive the need to say, okay, well, we need somebody who can navigate this, who knows where these paths lead, and ultimately help patients go this path, not that path, through the peer navigators you were talking about, John. Yeah.
Thank you all for this participation. I do see another resource was shared by Dr. Shorter, who is also part of our hub. Dr. Shorter, sorry to put you on the spot, but I'd love for you to introduce yourself to the group and maybe expand a bit on that resource that you just shared.
Absolutely. Good afternoon, everyone. Sorry I was a little late getting on the call. Daryl Shorter, Medical Director of Addiction Services at the Menninger Clinic here in Houston, Texas, and I'm on faculty at Baylor College of Medicine. One of the things, ASAM and AAAP, or the American Society of Addiction Medicine and the American Academy of Addiction Psychiatry, oftentimes do work together. Most recently, they put out a joint treatment guidelines for stimulant use disorder, which are fantastic. If you haven't pulled those up, I would really recommend that. So lots of work being done by both of these organizations. And so depending on kind of your leaning, you might also take a look at AAAP in addition to ASAM. And for folks like myself, we may tend to do both of those things. But great organizations and resources. And great talk, Dr. DeMoss. Good to see you.
You as well, Dr. Shorter. And thank you for the AAAP, great group of folks. And a lot of them, they work great together because they're, united behind one goal, right? So, but yeah, thanks for that, Dr. Shorter.
Thanks, Dr. Shorter and Dr. DeMoss. And I do see Bobby shared ASAM Practice Pearls is a good podcast. So if anyone has some free time and wants to listen to a podcast, check out Practice Pearls. In the interest of time, we will go ahead and move on to announcements. But thank you again, Dr. DeMoss. And I'll give Karen a moment to please share those announcement slides.
Thank you.
Wonderful. Thanks, Karen. So to claim your CME credit, you must text by midnight tonight. Please text attend 100-98497 to 844-502-1338. Next slide, please. Do you have a difficult case that you or your team have encountered? If so, CSTAT offers you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and broader learning community. There is no need to prepare a formal presentation, as we will provide you a case form to fill out in order to assist you with the case presentation itself. Please email us using the link in the chat if you're interested. Next slide, please. We invite you all to join us for the next installment of our webinar series, Thriving in SUD Service Delivery in the Post-COVID Era, on April 17th with Denise Beagley, who will be discussing coping with pandemic related grief, strategies for healing and resilience. Next slide, please. The Center for Substance Use Training and Telementoring, in collaboration with the Perinatal Psychiatry Access Network, also known as PeriPan, is excited to launch the Maternal Health Echo program on Tuesday, April 1st. This initiative provides free continuing education and offers essential training, consultation, and support to enhance care delivery for pregnant and postpartum women that are experiencing substance use disorder. Join us for the very first session. Join us on the first Tuesday of every month from 12 to 1 p.m. Central Time. Next slide, please. We are very excited to share that CSTAT by Be Well Texas is still accepting applications for our MOUD mentoring program. Join us for an opportunity for prescribers to receive personalized one-on-one mentorship to integrate MOUD services into your daily clinical practice. This exclusive offer is available to a select few in the Texas Public Health District Region 8, so don't miss out on this wonderful mentorship opportunity. Next slide, please. Please join us for our next session on April 10th. And that's it. Sorry about that. Had a little brain. Whoop. Okay, thank you. And so before we do move on to our case today, I'd like to remind everyone that no protected health information is allowed in either the chat or the discussion. And let's continue making the space inclusive and open to respectful dialogue. With that, Dr. Hurwitz, once Karen shares the case, please walk us through it. Thank you.
Okay, thank you so much. And thank you, Dr. DeMoss. I think that this case is really going to bring us into my case very well. Just as a caveat, I am on service and I am in the hospital. If it is hard to hear me or unexpected noises, I do apologize in advance. So this is a case that I experienced last year as an intern in internal medicine. It was a 43-year-old female Latinx patient. She came in severe opioid use withdrawal, and I realized that I had put my information in the wrong portion here. So it is not methamphetamine or amphetamine withdrawal. This is a patient who had severe opioid use disorder. She had been injecting fentanyl into her neck multiple times a day for many years, at least 10 years. And when I saw her, it was her second day in the service. So she had come in for acute chest pain and shortness of breath, and she was admitted to the ICU. The following day is when I actually met this patient. And when I met her, she was in obvious clinical severe withdrawal. She was vomiting, she was having diarrhea, severe muscle aches, chest pain. She was tachycardic and febrile, and she was extremely uncomfortable, very emotional at the time. And what we had done is we had actually called Dr. Weems and we said, what do we do with this patient who is in severe acute pain and withdrawal? And his recommendation was that we do IV dilated pushes until the patient was comfortable. And what this told me is that our hospital culture at the time was unfamiliar with diagnosing severe acute withdrawal and managing severe acute withdrawal. And we did stand next to the patient. We got her on a good regimen, which you can see here. We started her on 0.4 dilated IV pushes, Q4 PRN. We also gave her a longer acting 4 milligrams PO. And we started her on methadone, starting off at 10 milligrams, then increasing her to 40 throughout her hospital course. We did realize through her hospital course that she did have a recurrent tricuspid endocarditis that needed 6 weeks of antibiotics. And this was very complicated for her. If we can scroll down to her social conditions and psychiatric history, She had been living with a partner who she had used with for many years. Also living with her were her children. Um, some of her children were with other partners, and some of them were with her, living in the apartment with her partner. And throughout her hospital course, she had decided to completely come off of IV fentanyl. She wanted to be only managed on methadone. And her partner actually disagreed with this, and they ended up having an emotional end of their relationship while she was in the hospital. I was happy to meet her mother and sister, though, and some of her children who were extremely supportive of their mom. They loved her regardless of her use. They were always around to help her through her situation, and she was safe to discharge home with them. Just a little bit about her other history. She had had this tricuspid valve endocarditis in the past. She had actually had a vagectomy as well as an ICD placement, a 2-lead ICD placement that we carefully considered whether or not we needed to remove it with the recurrence of the endocarditis. But she was actually discharged on 40 of methadone twice a day with a rapid follow-up to methadone clinic. Gigantic shout out to Rachel Holloman who set that up. We had her follow in the methadone clinic the day after she left. And she left with a one-time injection of divalvacin, and then she came back to the emergency department a week later for a repeat injection, which is considered curative. And I did a chart review, and she was actually able to get a repeat valve replacement to completely cure her endocarditis. Important things that I learned about this from this patient is that we do not have a good withdrawal protocol in our hospital. So I actually want to shout out Dr. Brooks Keener, who is our current chief substance use champion at our hospital. He helped me develop a withdrawal program and a withdrawal protocol in conjunction with Alana Bolton and Dr. Weems, who's here. And I would like any advice on what you tell residents about how to approach severe acute withdrawal for patients who we are standing in front of them and they're clearly decompensating and not doing well. How do you treat their pain on top of the opiates that you need to give them just to meet how much they need? And where should these patients go? There was a lot of back and forth discussion about whether or not this patient was floor appropriate, IMC appropriate, or needed the constant care and watch in the ICU. So that is my presentation. I'm open to any questions, and thank you so much in advance for any feedback.
Thank you, Dr. Hurwitz. And yes, I'd like to open the floor for our case discussion. Are there any questions, comments, resources for Dr. Hurwitz?
John, you're not gonna step in and help your resident out here? Like,
Yakking too much already. If it's okay, I think it can be helpful maybe to just sort of like say with what was that like to have this patient who's clearly decompensating in front of you, right? And to be up against in a situation where you have a pretty good idea of what would help them and feeling like there's going to be a lot of resistance. Because I think a lot of us, that we have a lot of providers on the call, but then a lot of other care team members, and I wonder if it might be helpful to just sort of hear what that's like for you, as we're all part of systems that are hopefully growing and changing in good directions. What was it like for you?
Yeah, excellent question. It was shocking. I walked into the room. I had just gotten the sign off from the IC resident saying, this patient uses opioids, so we know it, and she goes into withdrawal all the time. And I walk in the room and she's so uncomfortable. She's hemodynamically unstable because of her discomfort, really not because of the sepsis. And we just hadn't been doing enough. I was like, we are in the ICU right now. We have one-to-one nursing care, and this person is vomiting, having diarrhea. Her entire body is in pain. She has a bacteremia. She's infectious, and we're not doing enough. We're not even addressing the patient by her first name. We're talking about her as if she's not in the room, which is inappropriate. And we are not in any way going to make this patient better and feel like this is a safe healing environment and a place where you can withdraw, and we will help you through it and set you up for success in the future. So it was very surprising. It was a little bit disappointing, and it told me that we needed to make a change, which is where calling you and getting all these people involved really started.
Just one quick question for you, Dr. Hurwitz. Do you recall what she was being prescribed prior to you coming onto the case? And you may have said that, but I'm just
So, oh, I'm so sorry. Yes. Sorry. She had not been given any opiates. She had only been in withdrawal until when we saw her. She had been started on antibiotics, and that's all.
Okay.
Because when she first hit the door, she was actually so encephalopathic, and she was difficult to arouse. And so nobody wanted to precipitate any further withdrawal, but she had not been given any pain medication up until that point, only initiation of antibiotics and fluids.
It sounds like they're the balancing, right? The clinical team, if they're worried about somebody who's decompensating and getting into the clinical stuff, right? If she has right heart problems, intubation is a nightmare and risk very severe decompensation for a bunch of interconnected clinical reasons. And then you have the patient in front of you who's clearly has a syndrome that's treatable and is telling you, I need something to get me out of this. One of the, there's a great paper, it's probably 15 years old now, sort of like from the M.Sc team, I'll link in the chat, about sort of misconceptions about pain in folks with opioid use disorder. And one of them is that people with opioid use disorder should not be exposed to full agonist opioids. Do you think that sort of bias or that stigma or that misperception was a part of the team's management as well, or do you think it was more clinical concern for somebody with altered mental status?
I do think that it was mostly concern for altered mental status, but I did also get the impression from the handoff, and I don't want to speak poorly about the residents who took care of this case. I think they did a fantastic job, and the team did what they needed to do. Their main concern was stabilization of the patient. There had been some previous interactions with the patient before where she had come into the hospital and left before interventions were started, and so I think there was concern that the patient might not stay long enough. But this patient was sick, and the patient knew she was sick, and she knew she would be here for a long time. And after we really started her on opioid therapy, she's a lovely, sweet lady. I think about her often. Her children and her family were just so loving, all of them, and they just really needed to be treated with respect throughout the entire process.
So sorry.
No, please go ahead.
So Dr. Hurwitz, what I'm hearing you say is a little bit of opioid therapy, maybe a sprinkling of buprenorphine, but a ton of respect is a great recipe for someone in this case. Is that what I hear?
Yes, I think so. I think that, of course, you need to stabilize the patient clinically and make sure you're not going to exacerbate any clinical issues. But then, yes, managing the patients with a known opioid use disorder is not something that we're trained well to do, especially early in our training. And so any advice on how to train, especially early residents, to recognize the degree of withdrawal and how to approach somebody who's in an acute withdrawal crisis would be greatly appreciated.
I'll throw a suggestion out there, which and then I'm gonna be quiet. But and sorry, John, to call you out on that earlier, but I was doing it from a system standpoint. A lot of places have a COWS protocol that are linked to buprenorphine dosing. That way, you can get an objective scale, much like a CWA for alcohol. If people are familiar with using CWA, COWS would link buprenorphine is a great way for, especially people who are not necessarily intimately familiar with, how to manage, opioid withdrawal in the hospital setting. Great way. We actually have here at my institution, we have a COWS, but it's not linked to anything. And so you get a score, which is great, but then you have to go in and it's more barriers. And one thing that I've gotten some of my early residents and actually a medical student on is linking those two. Like you get your COWS scale, and then maybe 4 milligrams of buprenorphine for this score, maybe 8 for this score, and so it's educational, and they learn process development, quality improvement, and so it's if you can get younger trainees on some of these process improvement kind of projects, it goes a long way, and the ripple effects are pretty deep and wide. So.
I love that idea. We do have a COWS protocol that is not linked to any buprenorphine dosing. I do think that's a great idea. I am curious, as a follow-up to that, on top of that correlative dosing, do you also have PRNs for additional pain? This patient in particular had endocarditis. She was in a lot of pain all of the time, and we had a tricky time trying to treat her additional pain on top of it.
Yes is the short answer, Dr. Hurwitz. So you would have both adjunctive therapies for either withdrawal management or pain management on top of a COWS kind of protocol, if you will. And a lot of times, depending on the severity of pain, we would reach out to kind of our pain management service, who would then maybe offer adjunctive agents like ketamine was one of them. And then other full agonists on top of the already established buprenorphine dosing if needed.
Thank you.
I do see a question came in from Michael Smith. What time period was involved with the methadone adjustment?
Yes, so we started her on 10 milligrams BID of methadone, I think the day that we met her. So that was on her day 2 of hospitalization. And then titration was every 2 or 3 days following as needed for her symptoms. And by the time we reached, I would say 3 weeks of her hospitalization, so halfway through her IV antibiotic therapy, she was stable on 40 milligrams twice a day. Whether that was changed outpatient, I do not know.
Thanks so much, Dr. Hurwitz. And I do see some kudos coming from Bobby Sessions. Bobby, would you like to unmute and perhaps expand on that and also the social work perspective?
I mean, I was just saying it sounds like she was supported not only from the medical team, but from her family too. And, it's not easy to end a relationship that you've been with somebody. There's a lot of bonding that comes with drug use. And so to be able to end that relationship and make the decision to go further on with her recovery using methadone and hopefully other support. So I just wanted to give a shout out to that. That's all.
Shout outs and praises are always welcome. Thank you, Bobby. Any other questions or comments from anyone in the audience or our hub team?
I was just gonna kind of reflect back on the first couple of questions and maybe suggest an approach to patients with sort of in opioid withdrawal who are not on medications for opioid use disorder in the hospital. It sounds like there are options, and one of the critical things is to try to center our patients in choosing what's best for them. So all I remember about this case, honestly, is you called me from the room. And that just says everything. You're with the person having a conversation about what's going to be best. And as you're talking through it, we can start with the patient, talk about what the options are, and work backwards to figure out what the best way forward is. Like Dr. DeMoss said earlier, the standard of care is to offer people the opportunity to be on medications by the time they leave the hospital. What are not options at this point, right? We talked about adjunctive treatment or just like supportive withdrawal, the old detox meds. Here, that could be, it's life-threatening. We're already in a very challenging situation where we need to stabilize the opioid tone to stabilize the patient, figure out what the heck else is going on and treat it. The other thing that's not an option at this point is naltrexone, short or long acting, right? So we're talking about buprenorphine, methadone, or the other option that we started with in this case is full agonist opioids. The thing to know whether somebody's on MOUD or they're physically tolerant to opioids, and this is sort of highlighted in the ASAM OUD treatment guidelines, they're going to need higher doses. And that can be a challenging conversation with some, but it's just a pharmacologic principle of tolerance. People who are tolerant of insulin for various physiologic reasons need higher doses of insulin. Ditto with opioids. So those are kind of the three options. And for people who aren't, and it's not like those options go away over time. We can just like in this case, methadone was layered on later on. We can transition folks to buprenorphine as well. So I think, if we think back 5 or 10 years ago, it was like, can we start people on bup at the beginning of the hospitalization? And it was this really loaded well, we got to figure it out right now. But sometimes when the case is complex and the patient's ambivalent, that's not a realistic ask up front because this person is trying to survive a life-threatening illness. So three options: methadone, bup, full agonists, and remembering that no matter which direction you go, there's always options you can work with the patient to keep in any of those directions. I was going to ask another one. It's one thing that comes up often, right, for our patients with SUD in the hospitals. There's concerns about visitors, and we treat people with addiction problems different than everybody else. So we encourage, our patients on the onc wards, we're saying, who's going to come visit today? For our pediatric cases, we do family-centered rounds, and then for SUD, we look with suspicion on people who want to see their kids. I really was touched by the part of your presentation where you're reflecting on this person's role as a mother. What was it like inviting her family members to visit? Were there challenges with that? Both for you, Dr. Hurwitz, and anybody else on the call who's encountered similar situations in hospital settings?
Yeah, definitely the first few times we met the partner, there was concerns because he was quite somnolent when he came in. But really what we noticed immediately is that the patient was more comfortable when her family members and partner were in the hospital room. And of course, that makes sense. She's critically ill. She has mistrust of the medical system, as would be to be expected given how much people were mistreating her. And then we got to meet all of her kids, and we even formed relationships with them. We knew all their names. They knew who we were. Meeting her family was incredible. They all, brought her food because the hospital food was terrible. They brought her clothes that made her more comfortable. They brought her trinkets from home that made her feel safe in her hospital room that she was going to be stuck in for weeks on end. So really working with the family increased medical trust, but also it just brought her peace and comfort and joy, which is something that our patients do not get to have a lot of the times when they're admitted to the hospital for a long time. So I really am very happy that we got to have that experience with her family.
I believe you stated when you were giving your presentation that she had come in a few times before, but had always left before you guys were able to start those interventions. Do you have any perspective on what the reasons why she met? Like in my mind, I'm speculating, right? I'm speculating that her pain may not have been treated appropriately, that her withdrawal symptoms may not have been treated appropriately. So she didn't feel safe. So she left before you guys were able to treat this critical illness, right? And it could have had a much more negative outcome if she didn't continue to come back. Do you have any insight on kind of some of the causes that might have been happening before this successful turn?
Yes, you're exactly right. There were instances where pain medication was not provided and safe withdrawal practices were not provided. And then there were also times where she was told, you need to be admitted right now or you're going to die, which is not a good thing to hear. There were also instances where she was told, you're going to be stuck here for 6 to 8 weeks. And she has children. Her children were very young. She had things she had to do. So when we were able to stabilize her and say, you need 6 months of treatment, or 6 weeks of treatment, or we can get you 2 injections, one this week, one next week. And as long as you come back, you're considered cured. I mean, that was a life-changing situation for her. It was ability to go home and care for her children. It was ability for her to remove herself from her partner and living in a space that she didn't feel safe in. It was an option for her to go see her family outside of the hospital. And all it took was a little bit of patience and collaboration, and understanding that the patient has a life outside of this hospital that we need to understand.
Major kudos to you and your team, man. I mean, she's probably alive right now because of your intervention. So amazing job.
Thank you to Advancements in Infectious Disease for Dibel Basin. Yeah, big on that. But thank you.
We have time for one more question or comment from any other hub member or our audience today.
I got one question and maybe just like a a crumb for a future either discussion or case. OPATs, outpatient parenteral antibiotic therapy, and risk stratification tools for those who have substance use disorders. There's not a great plethora of data to guide us. And so I'd be interested, was there an OPAC conversation or a risk stratification in your case, Dr. Hurwitz, and also to some of the other members, do they have an objective risk stratification tool that they use outside of the Alabama 9 that maybe we can potentially have a conversation around for future topics?
Yes, that's an excellent question. She had in the past received a central line for rapid resuscitation and had left the hospital with that central line, which was not being used for outpatient antibiotics. So our vascular access team was not comfortable with putting in a more permanent line, either midline or central for her. And especially because she had already what we considered to be seeded her ICD. At that time, they did not want to put on an additional line. Also, in discussion with her, 6 weeks of presenting to an outpatient facility was not something she was interested in. The 2 shots and saying, bang, boom, you're cured. She was very interested in that. I think she was not excited about walking out of the hospital with something in her neck or her arm.
Makes sense.
Excellent. Thank you, Dr. DeMoss, for your didactic presentation today. Thank you to everyone for your participation in our case discussion, for sharing your resources and wisdom. And Dr. Hurwitz, thank you for the case presentation and the wonderful care you provide your patients. In the interest of time, we'll move on to our summary of recommendations. Dr. Weems, the floor is yours.
Great. Thanks, everybody, for a great session. I can't count past 3 either, but 3 of the takeaways I got from DeMoss were when we're thinking about transforming our systems to better serve folks with substance use disorder, figuring out community need, aligning that with your organization's interests, detailing the costs of not acting and the benefit of acting, and then the later insight that data can always be paired with stories, and the power of stories from peers, especially those shared in public settings with elected decision makers, can be a powerful tool to use. We need to identify champions, and when we're thinking about getting buy-in, we can think broadly, think about coalitions, and then finally avoiding pitfalls. That was more than 3 points, but I took away a lot from that. And then in this case, there's a lot of different things we can offer our patients, but what's non-negotiable is offering respect and recognizing the dignity of the people we get to serve. And I think the case presentation and discussion really highlighted that. Yes, absolutely, we need to be talking about standard of care, teaching up, transforming systems, and offering people appropriate medical therapy, and at the same time remembering there's a human in front of you and serving them and breaking cycles of being in and out of the hospital and things not quite working. So really well done. Thanks everybody for joining, and we'll see everybody back in 2 weeks.
Yes, thank you so much, Dr. Reams, for that awesome summary. Thank you to everyone that attended today's session. As a reminder to claim your CME credit, please text by midnight tonight. Text attend 100-98497 to 844-502-1338. And we also kindly request that you complete the post-session survey using the link in the chat. We look forward to seeing you at our next Echo. Have a great rest of your day, everyone. Thank you.